Good afternoon, everybody, and a warm welcome to ARCFEST and to our person-centered complex care theme meeting. We're going to start off our meeting with a number of recorded presentations, including this one, to give you a flavour of some of the projects that are being done by those involved with our theme, and to give a flavour about the things that we could do in other areas moving forwards. So we've got presentations covering areas such as digital consultations, continuity of care, projects around our response to COVID, cardiac rehabilitation, and multimorbidity. You'll start to see those shortly after I've finished this welcome. The majority of the meeting then will be an open forum, which we've tried to make as interactive as possible. And most of you will be aware that over the past few months, we've undertaken a number of workshops where we've been trying to refine and distill the ideas that the partners would like us to pursue within the theme. Because person-centered complex care is massive, and we really need to think hard about what are the areas that we can focus on to develop some programmatic grants and also some implementation projects. So the focus of that session is going to be again on digital healthcare, which has become increasingly important during the COVID-19 crisis. Secondly, we're going to think about continuity of care, and many people have highlighted the real importance of getting this right, and how people with complex conditions can really miss out and fall between stools when services aren't coordinated adequately. And then we're going to focus on multimorbidity, and it's often people with multiple conditions that have the most complex care. And we're going to get you to vote to give your view so that we can further refine and build on our priorities. And we're going to have some fun, hopefully, developing some word clouds. So I hope you're going to enjoy this session, and looking forward to interacting with you in person in about 20 minutes. Thank you for your attention.
Hello there, I'm James Mitchell, and I work as a Clinical Research Fellow at the Institute of Systems, Molecular and Integrative Biology at the University of Liverpool. Today I'll give a short overview of a project currently in development that's led by the Liverpool Epilepsy Research Group in collaboration with Jenny Downing and the Person-Centered Complex Care theme at the NIHR Northwest Coast ARC. So we plan to investigate patient perceptions of remote clinical consultations for first seizures and epilepsy. And this is in response to significant changes that have occurred over the past 12 months, particularly with regards to outpatient care in the context of the COVID-19 pandemic. Social distancing and isolation guidelines have led us to move away from the traditional congregation of patients in outpatient waiting areas and move to remote clinical consultations, either by telephone or video appointment. It's likely that increased remote consultations may have a legacy effect after the COVID-19 pandemic, so it's essential that we assess the impact of such changes on a patient perspective, particularly looking at health inequality ramifications that may exist. So our primary aim is to ascertain patient perspectives of remote clinical consultations during and following the COVID-19 pandemic for patients in the first seizure clinic, as well as those patients with long-term epilepsy follow-up. We also aim to ascertain patients' views about the delivery of healthcare in the future. That's particularly regarding the preference for future remote clinical consultations. In addition, we'll attempt to investigate whether demographic, social, clinical factors impact on patients' experience of or their perspective about remote clinical consultations. And this will be the focus of health inequality. So we plan to recruit patients undergoing consultations for first seizures as well as establish epilepsy across 20 to 30 neurology centres across the UK, using established contacts from previous research that's led by the university. We have a target of 80 patients from each centre, and so we'll aim to collect data from 1,200 to 1,800 participants over a 6-month period. The survey will be administered using Qualtrics software, and each participant will be given an individual URL address to complete the questionnaire in their own time, typically given at the end of their routine clinical encounter with their clinician. The survey will be hosted here at the University of Liverpool using Qualtrics software, and will use skip logic, and this should improve functionality and ensure that only the appropriate questions are delivered to each respondent. We'll capture data on demographic details, deprivation index scores, clinical details, as well as the patient's experience of remote and face-to-face consultations, using both binary responses as well as free text data. We'll also directly ask participants their preference for consultation methods in the future following the pandemic. So at present, the survey has been developed with inputs from patient advocacy groups. Sponsorship approval has been ascertained, and we're currently awaiting confirmation of HRA ethics approval. And the anticipated launch date is the 1st of January 2021. So many thanks for this opportunity to give a brief overview of this project, and if anyone has any questions, please don't hesitate to email me. Many thanks.
I'm Jenny Downing, and I'm just going to give you a brief overview of a study that we're hoping to start soon, looking at remote consultations in primary care during COVID-19. COVID-19 has been a catalyst for changing how people access primary care. It's been needed to reduce face-to-face contact, to keep patients and healthcare workers safe and adhere to social distancing. Most primary care consultations have been taking place remotely in the first instance, really by initial e-consultation form completion on the internet or with help from a GP receptionist. This is then usually followed up by receiving information or by having a telephone or video consultation with a GP. If deemed clinically necessary, this can also lead to a face-to-face consultation. So none of these methods are new. They were used prior to COVID-19. But the adoption of some consultation methods by both primary care staff and patients was quite low and varied. But things have changed drastically recently. And this project gives us an opportunity to find out what healthcare professionals and patients' views are about those changes, and also to ask a bit about what their actual experiences have been. So, what are the aims and objectives of the study? Overall, we want to find out how a remote-first approach is changing primary care. We want to know what the impact of a remote-first approach is on patients' access to care, and also what this approach is having, the impact of this approach on the delivery of good quality primary care. In what circumstances can this consultation method be used best, and when is an alternative more suitable? We also want to make sure that we look in detail at any issues relating to health inequalities. So what methods are we going to use? We're going to take a mixed methods approach. We're going to ask patients and healthcare professionals to complete a short online survey. This will take place at 3 time points: at baseline, 3 months and 6 months. We'll also conduct a small number of qualitative interviews at baseline and at 6 months. We hope to be able to recruit people with the help of the Clinical Research Network via GP practices across the North West Coast. We'll use text messages to patients with links to participation information, consent and surveys, and we'll email surveys to healthcare professionals. The patient survey will also be promoted on social media. We're waiting for ethics approval, and as soon as we have it, we will be able to start the study.
Hello, I'm George Georgie, and I'd like to talk to you about Classic, which is capturing learning and innovation across the North West Coast during COVID. So the idea for Classic was initiated by the Seed Health Alliance, and the intention was to run the project across Lancashire and South Cumbria, but it was soon recognised that we needed to run the project across the whole of the North West Coast region. So what's Classic about? Well, Classic aims to capture examples of service changes in learning and health and social care that could be both transferable and important for future practice across the North West Coast and the UK. What we're looking for is innovative changes and changes that are transferable within and across sectors. So the study is divided into 4 stages. Stage 1 being the discover phase, where we ran a survey and collected examples of changes that have been implemented across the North West Coast. We asked the stakeholder group to select projects of interest, and where we were allowed to, we went to stage 2, which is the detail phase, where we approached individuals for an interview that we structured based on an established implementation framework, and we're now doing the analysis and identification of common themes. In stages 3 and 4, we're going to discuss and determine which changes should be retained and developed and agree priorities. We're going to involve the stakeholders that have taken part in Classic and others to help us make those decisions. So the survey response was good. We received 131 responses and there was a good geographical spread across the North West Coast. We had a good response from the NHS organisations and voluntary sectors. And the majority of responses were from staff directly involved in delivering services and care. However, we did also receive responses from areas like laboratories and pharmacies. Many reported the use of new technologies to offer remote consultation and changes in service access, and many reported that the changes that were pre-planned were actually accelerated as a result of the pandemic. We also asked respondents, was there anything else that they'd like to tell us? And we've grouped those under these titles: so catalyst and legacy, speeding up and leaving a legacy of change, how relationships have changed, how some have felt that things were streamlined and simplified and more effective, that there'd been a wider impact on services and working practices, that many organisations have shown great leadership and support and enthusiasm and adaptability to changes. However, some felt that there were personal and professional concerns that needed to be addressed. So thank you for listening to this presentation about Classic. If you'd like to find out any more information, please email me at the address shown on screen.
This is a project about cardiac rehabilitation for people with chronic stable angina, the ACTIVATE trial. This is a project for which we have received an intention to fund letter from the National Institute of Health Research Health Technology Assessment Programme, subject to satisfying the funder's final queries. So we're not yet able to publicise this widely until the contract has been agreed. Cardiac rehabilitation is currently available on the National Health Service to everyone who has had a heart attack or a procedure to improve the blood supply to the heart. It is not currently available to the large number of people with stable angina who are currently managed by their general practitioners. Although we might expect cardiac rehabilitation to work in this group, there is currently insufficient evidence to support it being provided by the National Health Service. One of the issues with the current cardiac rehabilitation programs are that they mainly appeal to white, middle-class men. Women, ethnic minorities, and people from socially disadvantaged backgrounds are poorly represented. We aim to tackle this by using an online program that people can access from home with the help of their family. The Activate Your Heart program is already widely used by the National Health Service and is becoming even more popular now that many rehabilitation programs have to be delivered remotely because of COVID-19 restrictions. The program uses behaviour change techniques such as education, goal setting and feedback. A paper-based alternative will be available for people who cannot access online materials or are unwilling to use them, despite the support of the rehabilitation team or their family. People will be supported by a cardiac rehabilitation professional who will introduce the program to them and will visit them again 12 weeks later after they should have completed all 4 sections of the program. People will be able to continue using the goal setting and feedback sections of the program for the whole 12 months that they are in the trial. They will also be able to contact their rehabilitation professional online and join a mutual support group. We plan to run a randomised controlled trial recruiting 518 people with angina from 20 general practices in Merseyside, Lancashire, North Wales and Leicester, targeting practices in socially disadvantaged areas and in areas with large ethnic minority populations. We aim to test whether the online cardiac rehabilitation programme is more effective than usual care in terms of patients' angina, shortness of breath, quality of life, anxiety, depression and self-efficacy, which is their belief that they can be successful when carrying out a task. These will be measured over a 12 months follow-up period. We will determine whether the programme is good value for money. We will also examine how well the rehabilitation programme is implemented and identify barriers and facilitators to uptake and completion of the programme.
I'm Jo Knight, Professor of Data Science at Lancaster University, and I'm going to talk about our project entitled Impact of COVID-19 Pandemic on Care Home Pathways, Outcomes and Safety of Care. Our team is comprised of academics, clinicians and data specialists from across the North, with 2 research assistants based at Lancaster University. We are tackling a significant issue. Deaths in both residents and care home staff has been high. For residents, it was 46% higher between March and June than it was in the same period in a previous year. And for staff, the risk of death is twice that of the general population. And the population we're talking about is not small. Between residents and staff, there are about 1 million people in the care home system. Policy was changing almost daily, with a significant U-turn from the starting position which stated that care homes were a suitable place to discharge patients with COVID to free up hospital beds. We are using a unique data set to explore what really happened. We have referral data from care homes linked by NHS number to A&E information, outpatient information and other hospital data. We're still going through the information governance procedure required to allow us to access this data, but when it comes, there are many questions we're going to be trying to answer. For example, we want to understand if more residents were cared for within homes and not taken to emergency departments. Were residents transferred back from hospitals with COVID-19 symptoms? What were the characteristics of people who were referred? And what were the resultant outcomes? Alongside the work on this dataset, Professor Nancy Preston, also from Lancaster, is collecting information through interviews with care home staff, residents, families, and the clinicians in the community to discover how decisions were made about the care home residents with suspected or confirmed COVID. This team will also analyse how different care settings took different decisions and implemented different management strategies and how that affected outcomes. Our findings can be used to inform policy in the ongoing pandemic and also inform on health service provision more broadly.
Hello everyone, my name is Sam Meredith and I am a new PhD starter here at the University of Liverpool under the ARC, and I'm going to be talking to you today a little bit about my PhD project, which is currently titled Multimorbidity Clustering to Inform More Equitable Health and Social Care. So a little bit about myself first. I'm 23 years of age and I'm a born and bred Scouser, as you can probably tell by my voice. I've got a direct background in mathematics, which I studied at undergraduate level. I then achieved a master's degree in data science in September of this year, and just this October I started my PhD at the University of Liverpool under the ARC in a topic known as multimorbidity. So, what is multimorbidity? What's my PhD about? So it's a simple concept. It's defined as when a person has 2 or more coexistent chronic conditions, and it's been identified by the NHS as one of the biggest health problems in the UK at the moment. So a couple of sound bites from current research. 2/3 of individuals over 65 are said to suffer from multimorbidity, and it's more prevalent in economically deprived areas. It's associated with a poor quality of life and an increased probability of mortality. And overall, it leads to an increased use of health services, which is why it's one of the biggest issues at the moment. So now we know what multimorbidity is, what do we want to try and achieve within this PhD project? So firstly, we want to identify the most common disease clusters in the UK, and we're going to do this through employing, machine learning techniques that haven't been necessarily employed before. We also want to pinpoint what demographics are most susceptible to becoming a part of these clusters. We want to collaborate with clinicians and identify models of care that better deal with multimorbidity, which has not really been done yet. And we also want to inform policy, inform governments on what changes need to be made to address the health inequalities that surround multimorbidity. So thank you for listening. I hope you all enjoyed that little insight into my PhD project and what I'm trying to do under the ARC. And I hope you enjoy the rest of your day. Cheers.
Hello, and thanks so much for inviting me to speak. There are fascinating Scottish studies of primary care patients which found that compared to the more affluent areas, patients in deprived areas had a higher prevalence of combined physical and mental comorbidity, which started at younger age, affected women more than men, and clustered with other social issues. The relationship between deprivation, younger age, and physical mental multimorbidity is becoming common in the whole of the UK and increases at a faster rate in the poorer areas. My PhD, based on general aging population of England, observed similar results. So, in my next project, I want to go deeper. I'd like to explore how social exposures and risks accumulate across individual lives to generate a complex biosocial nexus of multimorbidity centered around COPD. Such a study should focus on the area of Sefton in Merseyside, known for the largest health inequalities in the city region. I'd like to build on the work done by the Connected Health Cities project and extend their COPD hotspot maps into a rich three-dimensional narrative that takes into account the life course pathways leading to the COPD nexus, local history, and multi-layered social context. Given the critical situation around the Port of Liverpool, the study needs to unpack the role of air pollution in the clustering process. The Respiratory Medicine Unit in Aintree Hospital and Church Road Resident Association have expressed their interest in cooperating, so there is a chance that the study could contribute to environmental justice on Merseyside. Thank you for listening and look forward to your ideas and suggestions.